Thank you, Dr. Diksha and Chandigarh Ophthalmology Society for giving me this chance to present my work here today. And as you've given me the topic of ROP screening in these difficult COVID times, so I'll be dealing with what special we are doing for ROP screening these days. Uh, what is it? Why are these days special? Because there's a fear of unknown. We really do not know about the pathophysiology of this virus, how it is going to affect especially these newborns, which is an extremely vulnerable subset of patients. So some extra precautions definitely need to be taken. We also need to develop a backup team in case we are affected by the virus, and we have to see how to manage the lockdowns. So my presentation will basically be dealing with all these points only. So first of all, before I go ahead, just let me recapitulate that what are the babies whom we should be screening. Any baby born with a birth weight less than 2000 grams or with a period of gestation less than 34 weeks should be screened for ROP. And even beyond this, if the baby has had a very stormy neonatal course. We still get babies who have a treatable ROP, and when we ask the pediatricians, why don't you send them earlier? They said, okay, I consulted my textbook, and which is American textbook, in which it is written that these babies should not be screened. So you see, the knowledge has still not permeated that which babies should be screened. And I think we all have this service to do. We need to teach our neonatologists about the Indian guidelines, not to follow the Western guidelines. Uh, so what is the ground reality? That all other services during this lockdown period were stopped in eye hospitals. For example, in our hospital, we have 6 consultants, and during initial lockdown, I was only one working. So retina services, they have to go on because they have an element of emergency in them, and more so the ROP services. And especially if you are in a periphery and dealing with NICUs where there's a high rate of treatable ROP. Uh, from April to August, I have done 364 screenings. So you can imagine this. We have not stopped these services whatsoever. So how have we managed these lockdowns? So we have called and reminded the parents. And it is let's not think that this phase is over, because as we are seeing that India is peaking tomorrow, let's say we again have lockdown. So I think this presentation, these points can be taken home and applied if need be again. So we have been calling the patients, reminding them of the follow-up dates, and we have emphasizing to them the importance of follow-up. Less they think that there are more things important. Managing the lockdown is important. Getting groceries is important, but we emphasize that your child can go blind. Mostly our hospital staff calls them, but even if the parents they miss the follow-up, then I call them myself. And believe me, once the doctor calls them, the impact is totally different. An SMS can be sent from the hospital, which they can show to the authorities if they're being stopped by the police, or a printed OPD slip, not a handwritten OPD slip, because it may be difficult to be read by the policeman. So a printed OPD slip should be given, clearly mentioning the follow-up date. A written note that they should not be stopped from going to the hospital and it's an emergency. That goes a long way in preventing all the curfews and all. And parents should be given a personal contact number, that if they are stopped and if they are being hassled by the authorities, where they can call. It should not be a board number where they are frustrated calling here and there, but it should be a personal number of some manager, counselor, or a doctor himself. So these were in the happier times when COVID was not there. Our parents bringing the babies, they used to intermingle with the rest of the OPD, but no more now. Now we are taking extra precautions. But when you take or talk of extra precautions, one has to keep in mind that these extra precautions should be viable and repeatable. They should not become just a photo op, that once you do it and then it becomes difficult for you to follow the map again and again. And we have to think of long term, not with short term, that okay, today I do this, it becomes difficult, and tomorrow I leave it. So all these precautions we should be able to carry out on a long term, and they should effectively break the chain of transmission of COVID. And they should not be interfering with our screening and lasers, lest we become so involved in our PP kit or something else that we do a shoddy work of screening. This should not happen. And parents should appreciably note the precautions which the team is taking for their little one, because God forbid if tomorrow this child has a COVID infection, they should not think that they have caught it from the ROP screening time. So in NICU, we are using autoclaved or a sterile disposable gown, a snugly fit N95 mask, gloves, And speculum and depressor are sterile. Initially, we just used to wash them, but no more now. Now we use sterile speculum and depressors for each child. And there should be no unnecessary talking or shouting in the NICU because droplets will be generated. No unnecessary touching here and there. Just go in, do your work, and come out. Don't do some extra touching here and there. If possible, visit the NICU before you start your OPD. In your own OPD where the children are coming, there should be separate waiting area for the neonates and minimum stay in the hospital premise. The time involved with parents are there with their child should be minimum. Again, we are using gloves, sterile instruments, and if the stage of the disease is permitting, then we are prolonging the follow-up as compared to earlier times. So I'll be just showing you a video about what we are doing now. Is the video there? Is the video on?
Doctor, you'll have to stop the screen.
Yeah,
and
you'll
share.
screen sharing and then share the video.
I can't see.
You have to share your screen, sir. Yes, yes, we can see the video.
Okay.
Please go ahead.
So as soon as the patient walks in, they are diverted from the OPD to a separate area. The parents open the eyes and the staff member puts the drops. Again, minimum touching by the staff. So once the child is dilated, he is brought to the area where screening has to be done. So this is a sterile sheet. These are sterile instruments. And here, for the benefit of general ophthalmologists, I would like to show that how much time it really takes to do ROP screening, because it is believed that it is a very lengthy process. Many people, they don't do it just because of that. So you can see. So in under 1 minute, I think I have screened both the eyes. So after screening, we put 1 drop of antibiotic and we do not prescribe any antibiotics for home. Explain to the parents and hand them back their kid. This is doing a laser in a NICU, wearing a gown, gloves, and protective glasses. There's no shield or any other thing in which I become extra uncomfortable. Thank you so much.
Thank you very much, sir, for this excellent presentation demonstrating the how to go about doing screening and performing laser in these difficult times. And very rightly, you emphasized some of the key points is that to give a printed OPD slip with a clear follow-up date mentioning and preferably a written note so that they do not have problems in reaching to the hospital and possibly personal contact details and making it clear and emphasizing the follow-up schedule to the parents of the baby. I would like to invite comments from Professor Dogra on this talk.
I think Ajay has done a very good job. It was, I think, the most difficult talk given to him because it's in a different time that he's talking about the screening. But the way he has been doing and what he has emphasized, all the points, absolutely, those points are very, very important. And I think ours is one area where perhaps we have no choice except to do screening as well as treatment for these babies. So I think what he has said we must follow, and maybe some of you, those who are doing during this time, uh, I would say if any one of you have to add something, maybe Anand, you have something more here to add, that will be welcome.
I think all the precautions that Dr. Ajay showed is what we need to do. And the Indian ROP Society early in March itself published these guidelines. Um, of course, I think in our setup, we do most of the screening through imaging. So a few more extra precautions in terms of the tip of the lens and cleaning that has to be followed. We do, the small difference in the way Dr. Ajay showed is that we get the baby, the mother to bring in the baby and place it on a sterile place. And then the mother walks back and then we go towards the baby. This, you have to be really careful that the platform is stable. We don't want the baby rolling down, but usually these babies are small and they don't move much, but that's the only small different thing that we do.
There are two questions that have come up for this talk. One is for Dr. Ajay, that would you like to use an N95 with an exhalation valve or without one? And secondly, is it important to get a written consent regarding COVID taken from these babies, parents of these babies?
N95 mask without a valve is definitely better. And if you see in the video, I have one with a valve, but it is taped from inside, because our hospital bought these masks in the initial period, so we have lots of them lying with us, but now we have covered the inside with the tape. Is one thing. And as far as the special COVID consent is concerned, we are not taking it, to be very honest, and rather I would like to ask the other panelists, should it be taken, lest the parents, they become psyched out and they run away. So I don't know what to do about it.
We are taking a written informed consent because this is as per the AIF's guidelines also, that we need to take a written consent.
No, that general consent we are also taking from every patient who is coming to the hospital. Nothing special about ROP.
Yes, correct.
Dr. Ajay, one question, how about use of visor? Because I use visor in addition to this. That's a spectacle visor and it works well. I don't know whether it's how essential it is.
I couldn't use the visors. I tried in the beginning, neither for adults nor for kids. So I just use protective glasses which come in a PP kit. That also just in an ICU, not in my OPD for screening.
All right. I don't know what is the other panelists have in the comments about the use of visor while doing indirect ophthalmoscopy or laser. I don't know. The only thing I felt good was the spectacle visor. Otherwise, all other visors don't work at all.
In our hospital, all the adult and pediatric indirect ophthalmoscopy, all the indirect ophthalmoscopes have been fitted with a visor. So we are using it.
Yes, even I am using a visor for the screening part. It is definitely difficult while you're doing a laser. Okay, thank you, Dr. Ajay, for this wonderful talk. Now